And in a similar note, also the PG tips also will be continued by Shankar sir. So I think so it will be a good learning experience for the PGs, and I hope that the PGs utilize this and improve their academics. So congratulations to Dr. Jose and our Secretary Krishna Mohan and Shanawaz sir last year for having conducted the program in a beautiful way. And I wish Dr. Mohandas and his team all the best for 2024. So let's keep things going the way it is, and let's improve the academics in for the PGs, and let's do the best we can. Thank you. JAP, Jai Hind.
Thank you, Dr. Shami. Being the first program, I would like to invite Krishnavan also to speak few words. Secretary IAP.
Yeah, thank you, sir. So, respected State President, immediate past President Dr. Jose, sir, and the State Coordinator Dr. Mohandas, sir, and my dear postgraduate students. So, as Simi sir just told, this was one of our most prestigious and most successful programs last year, which was very well appreciated all over India. So, I hope this year also it will continue. I take this opportunity to congratulate Dr. Shanawaz, who led the program last year, and special mention about our State President 2023, Dr. Jose, because he was the person who was very particular that we should not miss even a week. Every week we should have a program. He was very particular about that. So I wish this program all success. I once again thank Mohandas sir for taking the lead for the next year. Thank you so much.
Thank you, Krishnavan. Now we are directly going to our program without wasting much time. So today's lead discussant is Rajit Kumar VT, who is the professor and head of the department, Government Medical College, Thrissur. Dr. Rajit was in Calicut as HOD. He's my classmate right from the MBBS and then for PG. And he has had his special qualifications in pediatric hemato-oncology, and he has been conducting the pediatric hemato-oncology clinic and unit in Government Medical College, Kozhikode for last several years. And so I would like to invite Dr. Ajit, and today's mentor is Dr. Latika Nair, who is the additional professor in Government Medical College, Thrissur. I would like to invite Latika also. Over to Dr. Ajit.
Thank you, Dr. Mohandas. I'm very happy to see that the program, which was started by none other than my dear friend Dr. Jose in 2023, is being carried out and carried forward in a great way by Dr. Shimmi. I'm also very happy to see many of my teachers here also, Sushma Madam, Parvati Madam, and Purushottam Sir, and also my classmate, special mention, Dr. Sajida is also there, in addition to Dr. Mohandas. And I'm really thankful to Latika Nair for giving this chance to share this session by our own postgraduate student, Vishnu Priya, a second year postgraduate student in GMC Thrissur. And I think let's start. I think our stalwarts here, Sushma Madam, Purushottam Sir, and Parvati Madam, can intervene in between and make this more fruitful. Thank you. And Vishnu Priya, please. You can start, Vishnu Priya. You can start sharing the slides.
So it will be advisable that those who have anything to mention in between, they can chat in the chat box. And if you want to ask the questions directly, please keep it towards the end so that the presentation and the discussion continues uninterrupted. And all the questions can be dealt with at the end. You can mention the questions in the chat box also, which will be noted. And if the Dr. Ajit decides to answer, then he may answer. Otherwise, it will be answered at the end. Thank you.
Okay, Vishnu Priya. Start.
Yes, sir.
You can make
Good evening, everyone.
that slideshow.
Okay, sir. Good evening, everyone. I'm presenting a case of 6-month-old male child who was residing from Bhavana of Delhi, was brought to Kerala 1 week back, and the informant was mother and her reliability was good. The child was referred from a local hospital to Government Medical College Hospital Thrissur with the complaints of cough and rhinitis for the past 10 days, followed by bluish patches over the body for the past 7 days. In presenting illness, the cough started 10 days back and it was a wet type of cough. The cough was associated with nasal discharge, but there was no fever or breathing difficulty or poor feeding or poor activity. And during their travel from Delhi to Kerala, the mother noticed the bluish patches over the back for the first time. And she noticed it to be 2 to 3 in number and progressively increasing in size, followed by other patches over the abdomen, scalp, thigh areas. And those patches were larger and palpable by the mother. The child didn't have any history of bleeding from the nose, oral cavity, or reddish spots in the body, no history of bleeding in the urine or stools, no history of joint or limb swelling or excessive cry during handling the baby, no history of recent fever or recent infections, no history of paleness noticed by the mother, no history of tattooing done to the baby, no history of external application of herbal medications, no history of yellowish discoloration of eyes, high colored urine, or itching, or abdominal distension, no history of pale stools, no history of trauma or loose stools or decreased urine passage. There was no excessive crying or irritability or abnormal movements and posturings or paucity of the limb movements.
So what are the presenting complaint is mainly respiratory symptom like cough. What was it? Cough and a bluish discoloration of 2 to 3 in number of how many days duration? 10.
Cough was 10 days, sir, and bluish patch
and bluish patch of
for 7 days.
Okay, so you said that there was no evidence of any severe illness. How will you classify that any child coming with cough and fever into according to ARI control program, Vishnu Priya?
Sir, presence of fast breathing and presence of chest indrawing.
What are the two types? How will you classify pneumonia?
Pneumonia is classified as presence of pneumonia, no pneumonia, or severe pneumonias.
Very good. So this child does not have any features of very severe pneumonia or pneumonia. There is no
Yes,
fast breathing and only maybe no pneumonia with upper respiratory symptoms, or a child has cough of 10 days duration only. No fever.
yes. No fever, sir.
Okay. And regarding the bluish patches, what are the causes of you might be thinking of bluish patches? It is larger. What do you think? Whether is it petechiae, purpura, ecchymosis from the history?
Sir, from the history, since it is increasing in size and all, and initial size was larger according to the mother, so I would think it is ecchymosis, sir.
It's palpable also.
Yes, sir.
Is it what is petechiae? Which is a smaller petechiae or ecchymosis? Petechiae, purpura, which is smaller. What you know the size?
Yes, sir. Petechiae is less than 1 millimeters, and purpura is 1 to 3 millimeters. Ecchymosis more than 3 millimeters.
So there is ecchymosis. There's a child coming with ecchymosis. So what are the causes of ecchymosis? What are things you have to have in mind?
Sir, it can be first. It will be due to bleeding in the skin or deep bleedings. So it can be platelet disorders, or if it is a deep bleeding, it will be coagulation disorders.
So how will you differentiate clinically, history-wise, by whether it's we want to differentiate whether it's a platelet disorder or a phase 1 disorder or a coagulation disorder?
Sir, if it is a platelet disorder, there will be small superficial involvement, like only bleeding in the skin and maybe in the oral mucosa. If it is a clotting disorder, there will be deep bleeds and there will be complaining of limb swellings or joint swellings.
And say hemarthrosis or hematomas, huge hematomas, hemarthrosis.
Yes,
Okay,
sir.
then other how will you differentiate any other feature between
Sir,
platelet type of bleed and coagulation type of bleeds?
yes, sir. Platelet disorders, platelet disorders, there will be bleeding immediately, and in clotting disorders, there will be bleeding after some time. I mean,
Delayed. Yeah,
delayed bleeding.
you have sprain in the ankle and then you have a swelling in the evening. Sprain in the ankle in the morning, you'll have a swelling in the evening. Also some delayed bleed. Okay, then any other feature which might be helpful?
In
you may have where do you have more family history? More family history in coagulation disorder or platelet disorder?
In clotting disorders.
Yeah.
In coagulation disorders, there will be clotting
More.
history.
So can you think of so from here, what do you think, like whether it's a platelet or a coagulation disorder? You're not very sure. No hemarthrosis, no hematoma.
Yes,
So you can say that without telling that no joint or limb swelling, you can say that no hematomas, no hemarthrosis. You can use that word hematomas or hemarthrosis. No mucosal bleeds. You can say that that terminology can be used in the history of presenting complaint. No mucosal bleeds, no hematophesias, no hematuриas, or dark colored or malignant. So these are the terminologies that we may use, and also no pallor. So any other thing? What about no other causes of with related to coagulation, a bleeding child, non-bleeding causes of ecchymosis?
non-bleeding. Yes, sir. Sir, it can be due to excessive handling of the baby, leading to hematoma.
Or I mean, do you have any other terminology? Like, it's not excessive handling. No excessive handling can produce bleeding, ecchymosis. Can you think of some condition where the child is neglected?
Battered baby syndrome.
Battered, yeah. So battered. So always have this in mind when you're talking about, especially when you suspect a ecchymosis to be considered to be a battered baby or Vishnupriya.
Okay, sir.
Any other? What type of ecchymosis will you have?
Sir, ecchymosis in unusual areas.
Very good. Unusual areas, and also you may have other features of injury, sometimes a fracture or some other
yes,
evidence of neglect, and all these things might be seen. So you have to look for that, especially any other cause other than bleeding disorder for ecchymosis. Some palpable, especially palpable. Have you heard of palpable?
Infant leukemias.
Yeah.
Infant leukemias.
So leukemias, they present with platelet problem, no? Other than bleeding disorders. Anyone? Yeah, somebody, Dr. Hasna has said it could be vasculitis. Is it not? You may have vasculitis of different. So vasculitis may present with ecchymosis or palpable purpura type like of bleed, and so you have to be aware of these conditions as well. Okay. So what history you will elicit in a child with vasculitis?
Easy bruisability will be present.
The bruisability and also other features of joint pain and rash and all these things.
Yes.
So these are the approach that you should have in your mind when you're dealing with the history of breast income. Okay, past history. So what past history you would suggest will elicit in a patient with ecchymosis? What past history? Go to the
similar
past.
episodes.
Go to the past. Yeah.
Similar illnesses in the past, we have to ask about it.
Okay, very good.
History of bleeding or swelling.
Okay.
History of prolonged bleeding or swelling after trauma or vaccination. And in the past, we have to ask about history of drug intake and blood transfusions.
Okay. Prolonged bleeding after trauma. Okay. Correct. So the no significant past history. Vishnupriya, your voice is breaking. Are you in a place where there is
Yes, sir.
no problem? So what does it indicate? Like that why we are asking all these things, past history? Why do you want to look into the past history?
Sir, history of similar illness might be patient might be having immune thrombocytopenic purpura.
One important thing is to whether we are dealing with something congenital, very early onset. Whether early onset, most it could be related to a congenital. We want to know whether it's an acquired disorder or a congenital disorder. So you have to ask whether there is a history of any what you call bleeding after tooth extraction, after vaccinations, and all these things are very important. Okay,
Yes.
one of the important idea that we have to have is to find out whether we are dealing with a congenital or acquired disorder. Okay.
Okay.
Yes.
In antenatal history, it is the first child of third degree consanguineous parentage to a 20-year mother and 22-year father. No history of abortions in the mother. And first trimester and all trimesters were uneventful. The mother didn't have any fever with rashes or painful swelling behind the ears. No history of UTI, joint pain, or radiation or drug intake in the mother. In second trimester, mother quickening was felt at 5th month. Anomaly scans were normal. Mother took iron and folic acid tablets regularly. No history of gestational diabetes mellitus or pregnancy-induced hypertension or bleeding per vagina. In third trimester, mother continued to perceive the fetal movements. Growth scans were normal and no other abnormal histories.
How many antenatal checkups they had?
Sir, according to them, she went for 4 antenatal checkups.
Okay, so minimum 4 antenatal. Did they have this anomaly scan and all?
No, but they told scan was normal, sir. They were not having the scan reports.
No, anomaly scan was normal. They had anomaly scan. Okay, right.
Yes.
Why I am asking, because they are just continue. Continue.
The baby was a term baby with a birth weight of 3.5 kgs. Baby was delivered by emergency LSTS due to failed induction. Baby cried soon after birth and breastfed within 1 hour of birth. And urine and meconium was passed within 24 hours.
Okay.
No history of umbilical cord bleeding or delayed fall of umbilical cord. No NICU admissions or hypoglycemia or jaundice in the baby. Baby was discharged on postnatal day 7 and child was having adequate weight gain.
So why you are concentrating on delayed umbilical cord bleeding or delayed fall?
Sir, delayed fall of umbilical cord is seen as factor 13 deficiencies.
Very good. Okay. So what are the features of in a newborn which shows that there could be a bleeding disorder or a coagulation disorder? What are the features in a newborn that you may think of?
Sir, if it is due to clotting disorders, there can be involvement of liver in the form of jaundice.
Clotting disorder, jaundice? No, I mean, when did you suspect a bleeding disorder in a child, in a newborn baby? Anyone in the chat box? What are the features? What are the features? Excessive bruising, delayed excessive bruising, bilateral cephalomatomas. So all these things are. And if you have a intracranial bleed in a child, in a normal child with a normal delivery, IVH, bilateral cephalometoma. Somebody said cephalometoma, but if it's bilateral cephalometoma, think of and bruising, excessive bruising, and all these things are features in addition to delayed cord. Okay, development.
Development history is normal. All the milestones are attained within the normal limits.
So all the developmentally child is normal.
Yes, sir.
Okay.
Immunization history. The child is a partially immunized child. They have taken vaccination up to 1.5 months. No history of prolonged bleeding following injections. No adverse events following immunization, and child has PCT scar.
Okay. What are the vaccinations child had taken? Like now the child is 6 months, no?
Yes, sir.
Only up to 1.5 months. You can
Yes.
note down the reason also why they had why up to. You always say the reason why they had.
Yes.
When you're presenting in the exam, it's very important to look at immunization. Why they had.
Yes, sir. It was because they were traveling a lot for their work, so they were not in a single place at a time. So.
Okay. Right.
Dietary history. The child is a 6-month-old child, and his child is been exclusively breastfed up till now. And then the child is having adequate weight gain.
Has been exclusive breast. So till 6 months. So now what's the age of baby? 6 months completed or?
6 months and 2 weeks, sir.
So okay. So what do you do like at this period? What will you advise?
I have advised them to start complementary feeding, sir.
Okay, what complementary feeding? Because they are traveling, no? They are from North India. What will you advise?
Sir, ragi is easily accessible. So
they're
powders.
traveling, no? They're traveling people. So when ragi, is it available for them?
Sir, we had powders in our hospital.
No. What you can advise, like, you can have rice, dal, and you can the very common name is khichdi, no? Have you heard of khichdi? Khichdi? Have you heard of khichdi?
Yes, sir.
Khichdi is one where you mix all these vegetables and dal and all these things, and that's a very good weaning food. Like complementary feeding can be advised for, especially for North Indian people. Ragi may not be available for them, especially as they are traveling.
Okay, sir.
Because up till now the child is normal, the development, growth, and what's the problem when you are not introducing good complementary feeding? What does Dr. Elizabeth Madam say? They may fall into. Anyone in the chat box? Where do they fall? If they're not giving complementary feeding correct. Just look at the answers. Anyone? Yes, somebody. Mohandas answered. I don't know. Geeta, yes, only. Geeta, yes, and Mohandas, both are my classmates. Anyway, the bit of malnutrition. Actually, if you read Elizabeth Madam's book, what is the program that how many days? What's the program called? First, how many days program?
What? 180 days.
1,000 days. Up to 2 years. Okay, family history.
Family history. Child is born to a 3rd-degree consanguinity marriage. No history of excessive bleeding or transfusions, chronic infections, joint-related symptoms in the family.
All PGs who are attending, please read the MIYCF program.
Okay.
Read the. Please unmute all others.
Take her with you. Why? Let her have some fun there, no? No, she can have fun there doing all this. Just take her, no? He'll enjoy.
Read the MIYCF articles and programs, and you should be okay. Please unmute Vishnu Priya. Okay. Continue.
Yes. Socioeconomic status. They were migrants, and the father is a Dolak salesman. Mother is a housewife with an income of 600 rupees per day, and they have a own house at Delhi. They belong to upper lower class of modified Kupuswami scale.
So how many months they are traveling, that you can ask?
Okay.
I think from the history, what I heard that they travel around 10 months a year, and only 2 months they are at home. Okay. Right. Please continue.
So coming to the summary, this is a 6-month-old male baby, previously asymptomatic child, born first to 3rd-degree consanguineous marriage with an uneventful past perinatal and developmental history. Child was partially immunized with no history of bleeding following immunization. Now presented with upper respiratory infection and bluish patches all over the body, which were increasing in size progressively and becoming palpable also.
In the social, can you go back to the social history? Like you can always add whether they are attached to the child and how much they are they're bonding to the child, because that is very important. Because I told you that sometimes you may have coming who is a victim of child neglect or child abuse. So that can be added in the where the child is how the father and mother.
Okay, sir.
What is a microenvironment? Anyone? What is a microenvironment? Anyone? What is microenvironment? Anyone in the chat can just type that microenvironment. What is microenvironment? Vishnu Priya, if you know, you can. Microenvironment. Microenvironment is the immediate father. It's a father, mother, child triad. That's the microenvironment. So any problem in the microenvironment will affect the baby. Okay. Right.
So with this summary,
summarize once more.
6-month-old male baby, child was previously asymptomatic, born first to 3rd-degree consanguineous marriage with uneventful past perinatal and development history, and child is a partially immunized child with no bleeding following immunization, now presented with upper respiratory tract infection and bluish patches all over the body. The size was progressively increasing and becoming palpable.
Okay. So what are the things that you possibilities in this child? Or all of you can just type in the chat box your possibilities 1, 2, 3. Okay. What are the possibilities?
Yes, sir. Sir, since there is a bluish patch in the child, I would like to consider there is a bleeding in the child, and it can be due to platelet disorder or coagulation disorder. So I would like to consider malignancy because in bone marrow infiltration due to bone marrow infiltration and low platelet count can lead to bleeding.
So this child is what are points against malignancy in this child? So
the child is a well child, not a sick child, and there is no involvement of other cell lines.
Yeah, you specifically said that there was no history of pallor or.
Yes, sir.
Okay. And no fever.
Yes, sir.
No fever. Did you mention about bone pain?
Bone pain, I told excessive cry during handlings. Yes, sir.
You said about that. So there is no bone. So there are many features against malignancy. This is not. But still, you consider any other, because this child had a fever, cough, and all these things. Any other possibilities?
Sir, it can be due to infection-induced platelet disorders.
What infection?
Sir, viral infections induced platelet disorders.
I mean, what viral infection can produce platelet problems?
Sir, Epstein-Barr virus.
Okay. But is the 6 months Epstein-Barr virus common?
No,
6 month
sir.
old? Not common, uncommon. Very, very
Yeah.
uncommon.
Yeah. And or intrauterine infections like cytomegalovirus induced platelet
CMV.
disorders.
What are the points
CMV.
against CMV?
Sir, but the child was a term baby and the child had adequate weight gain and there was no jaundice.
Okay. Child had a good weight, birth weight was 3.5
Yes.
kg.
Yes, sir.
So
Birth weight was no.
can it be another viral infection like dengue or something like that?
Yes, sir, but there wasn't bleeding spots were not there. And child didn't have significant fever.
There was a bleeding spot. No fever. Okay. No fever.
No irritability or means excessive handling, crying and all was not there. Joint
So
pain
no
was
fever.
there.
Was no fever. Okay. So one possibility could be maybe child had a fever, viral induced thrombocytopenia because of fever may not be may not be recorded, but they are because this child had a cough and associated maybe a very second other possibility.
Other possibilities might be again HIV induced thrombocytopenia or tuberculosis induced thrombocytopenia.
Why HIV you're bringing in HIV? When do you have thrombocytopenia?
Sir, in
Chat box, chat. Anyone can?
Stage 3 of HIV.
When do they have? What are the initial stage of HIV you can have? What do you call that?
Asymptomatic
Which type of
stage.
Which type of illness you have in it? Which type of illness you have? Type of illness. Dash type of illness. You may have. You can have thrombocytopenia.
Unexplained thrombocytopenias will be there.
One in the chat box. So IMN-like illness may present. IMN-like illness may be presenting feature of an HIV, but because they are traveling people, you have to think of an HIV. Okay, so that is one. Then
Sir,
what? Any other possibilities?
So tuberculosis induced thrombocytopenias.
Tuberculosis is unlikely. No, you don't have tuberculosis in a child who is 6-month-old baby. Which Dr. Geeta S wants to know what is the ethnicity of the child.
Sir?
Any other common conditions that you think of?
Malaria.
Like no. Malaria is no. Malaria can be there. Malaria can produce thrombocytopenia definitely. And any other possibilities? Commonly that you see in the ward comes with platelet thrombosis. You have ecchymosis. Very common. Sudden onset of ecchymosis.
At IT, immune thrombocytopenic purpose.
Immune thrombocytopenia. Very good. So think of that. Think of common conditions. Don't think of unusual conditions like HIV. Tuberculosis. Tuberculosis is very. So ITP. What is ITP?
Immune thrombocytopenic purpura.
Immune thrombocytopenic purpura. Okay. You may think of congenital thrombocytopenias, but think of ITP initially also. Understand? And so infection induced, then immune thrombocytopenia. So immune thrombocytopenia, will you put it immune thrombocytopenia top in the list?
Sir,
then malignant.
So but the age of the child is 6 months only.
Yeah,
so
you can have immune thrombocytopenia. Yeah, 6 months you can have immune thrombocytopenia. So I would put immune thrombocytopenia in the top of list. Second possibility could be a malignancy. Third could or infection induced. And third could be a malignancy. Okay, this should be my order. Can you think of other coagulation type of disorder?
Coagulation factor, yes, sir. Coagulation factor disorders, since it is a male child, there is a possibility of hemophilia.
Yeah, so you can have hemophilia present as ecchymosis. You have seen children coming with. So that has also to be in your mind because it's a well child. Don't have the thing that it could only be a platelet type of disorder, you have to think of coagulation type of bleed as well.
Yes.
Okay.
Yes, sir.
And where is the site of bleed? What was the site of bleed?
Sir, initially it started over the back of the baby, and then after that abdomen, and then scalp and thigh, sir.
Scalp and thighs. And this back of the baby is one area that especially for what?
Sir,
Child use. Or if you have battered baby,
yes,
basically they have the back of the baby area. Unusual sites.
Yes, sir.
So that, right.
Okay, sir.
Yes, so continue the examination.
In general examination, the child was an alert baby and the child was playful. Vitals were normal, that is pulse rate 92 per minute, normal in volume or character, and the BP was normal. Child's respiratory rate was 28 per minute, and child's room saturation was normal, and the child was afebrile. No pallor or icterus, cyanosis, clubbing, lymphadenopathy, and no edema was noticed.
Okay. Can you just go back to the... So temperature is, the child is afebrile.
Yes, sir.
Right, continue.
In head-foot examination, the child's head size was normal. Frontal pausing was present. AF was normal, 1.5 into 1.5 centimeter. There was no bulging in the AF. The child had a doll-like faces, and eyes was normal. No pallor, cataract, or jaundice noticed. No conjunctival hemorrhages. Fundal examination was normal. Nose, no bleeding. Oral cavity, there was no petechiae, no oral thrush. No ear bleeding or discharge.
Okay. So 6-month-old baby, I'll just ask a question like 6-month-old baby coming with recurrent infections, and there is a bleeding, there is discharges from your ears, chronic discharge from the ear, and what will you think if you have thrombocytopenia with recurrent?
Viscotaltic syndrome.
Yeah, viscotaltic. Yeah. You think of any other condition which can produce thrombocytopenia? Chat box, other pages can have thrombocytopenia other than HIV, but Langerhans cell histiocytosis, we may have discharge very good. Then common variable immunodeficiencies. You may have common variable immunodeficiencies, GSD, glycogen storage disease, and all these things you may have. So these are the conditions you think of. Have you heard of common variable immunodeficiency, Vishnupriya?
Yes,
so all these things can produce immunodeficiencies with thrombocytic bleeding tendencies. Okay. Because you said about doll faces, no? So doll faces, where do you get doll faces?
Sir, it is found in glycogen storage disorders.
GSD, mainly in GSD?
Yes, sir.
Which GSD? Mainly in which GSD?
Sir, in type Von Gex.
GSD1, okay.
Yes, sir.
Thank you. So continue. Eyes are normal. So that's a very important finding. No, you said doll-like picture. Do you have the picture?
Sir, this picture.
No, picture of the doll face of the patient.
This one picture only, sir.
Which one picture is that? I'm not getting it. Okay. Right. So what are the findings here like?
Sir, there is cheeks are chubby.
Okay.
And
the frontal bossing is very prominent, no?
Yes, sir.
So what are the features of what are the causes of frontal bossing?
Sir, it is seen in via nutritional rickets and
very good.
And extramedullary thalassemias.
Thalassemias. Okay, even chronic iron deficiency anemia you may have?
Yes.
Any other hemolytic anemias? Sometimes I think Mohandas might agree that achondroplasia may also have this this one. So chronic anemias can produce a frontal boson. So not only that, the GSD. This is Mohandas, do you believe that this is dog-like fishes? Mohandas, can you just unmute? Mohandas,
chubby, but in a situation where you're considering GSD, you can think of.
That's you just log out from one of your device. Thus, there is a echoing.
Because once she says that dog-like fishes, you are committing to one diagnosis. No, you're more or less going in one direction. So, but I think for the PGs, it is very important to tell the then committing on whether if it's a total dog-like fasciitis, I would say that you are committing to a diagnosis. So, other than that, it's better to if you have differential diagnosis, it is better to better describe the features in the exam. So especially if you get a mid-diastolic myoma with pre-systolic accentuation, you're committing to one diagnosis. Just like that, you're committing to a diagnosis. Like if you have a doll-like fissure, then you're going in one direction. Anyway, we'll see whether we can look into it. So Mohandas also agrees that there can be, it could be a doll-like fissure. Even I think that's a chubby face and a front. You can say that there is a chubby face and a frontal bossing and all this. Right.
Okay. Examination of neck, there was no petechiae, no lymph nodes. In chest, there was no deformity, no petechiae, no bony tenderness. Abdomen, there was a ecchymotic patch, 4 into 4 centimeters, over the anterior aspect of the abdomen with the central nodularity present. And there was multiple ecchymotic patches over the back, maximum 1 into 1 centimeters, and also over the thigh.
What is the importance of different age of the this one? Different battered baby have different of this different ages, even fractures also of different babies. Yeah,
yes, sir.
Yes. Okay.
And the baby's genitals were normal, and in the arm, no thumb anomalies, no absent.
Are they palpable? Are they palpable?
Yes, sir. That was central nodularity palpables. Okay. No thumb anomalies, no absent radius, no fractures.
Okay. What are the thumb anomalies? What are the hand anomalies? Why do you want to look at the thumb anomalies and absent radius and all this?
Sir, a hypoplastic thumb or absent thumb is found in Fanconi's anemia, and absent radius is found in TAR syndrome.
Okay, right. So if you have dysplastic nails or dystrophic nails with thrombosis and also leukoplakia, what do you think? Anyone?
Yes, keratosis congenital.
Very good. Keratosis. Right. Continue.
Okay. Anthropometry was the child was normal. Weight was within 50th to 90th centile, and the height was within 50th to 90th centile, and head circumference was also normal. So
basically, child was so despite they are giving good nutrition and child's despite being on a what they call always on a move, they're taking care of the child, isn't it?
Yes, sir.
Right.
Development assessment was normal.
Normal.
Yes, sir.
Everything is normal.
Coming to systemic examination.
Can you go back to the development once more? On basis and unit structures post transfer objects of the smile signal. And can you go back to anthropometry once more? Just a comment on anthropometry. Good. Better to write which standard deviation they have also. Okay. In addition to standard, with standard deviation.
Okay.
Anyway, it's normal.
Okay.
80 height is
16
in the lower side, no?
Expected cannot be 80.
It's not expected, it is below 6. Height is 69, no? It's in the lower side. Which centile?
Maybe it's only 6 months now. Expected will be somewhere around 65.
Yeah. Right. So
again, what is the last column? Weight by length. What is it?
For length.
Weight for length. What is that observed is? I think what's the expected at 6 months? The height. Chat box.
60.
Expected.
65.
Is it you're writing? Is it 90 or
60?
Expected at 6 months?
0.6 into 6 plus into 6.
Calculation went Vishnupriya. At 1 year, what do you expect? 1 year, 175 centimeters. Now we have written here 80.6. Obviously, it's totally wrong.
This is wrong, no? Understand?
Yes,
so
sir.
this expected is not 80.
Yes, sir. Yes, sir.
Understand?
Okay.
So you go back to calculation and then see.
Okay.
So one this I think to go back. So 69 centimeter. I think it has he overgrown.
Is a
Length.
child.
Anyway,
Is...
don't worry. Go back to that anthropometry and looks like the child is normal, and your expected is not here, not correct. It is anyway. Okay, as Purushottam sir said, it to be use that. Okay, right. Continue.
Okay.
Always when you measure, tell about the measurements, just mention about the parents' measurement also, especially the parents' height and weight and all, because it seems to be a little on the higher side. You expect somewhere around 65, here it is 69. It may be just a normal thing because parents are tall. That's a 63. It is normal, 43 is normal for a 6-month-old baby. So there also, always in the younger babies, head circumference should be accompanied by the parental measurements. So
what is Dine's formula? Anyone? Dine's formula? Anyone? Dine's? Anyway, so when you're writing less than 2 years, you have to write that it is length, not height. And more than 2 years only, you write height. Okay. Dines are anyone? What is Dines? Can just anyone type? Hello, Vishnupriya, what is Dine? You're comparing the length with the head circumference.
Okay.
The formula 18 months plus 9/2 plus or minus 2.5. Okay, that's the Dine's formula. And that can be used here also because used in the apparently for frontal bossing and all these things, you can use the Dine's formula and length also for the. Okay. And Purushottam sir said you have to look for the mid-parental. And okay.
Okay.
Anyway, these are all corrections for improvement.
Okay.
Yes, right.
Yes. In systemic examination, coming to gastrointestinal system, the upper GIT was normal. In abdominal examination, on inspection, the shape of the abdomen was normal and all quadrants were moving equally with respiration. There was an ecchymotic patch of 4 into 4 centimeter over the anterior abdomen. There were no visible scars, no sinuses, no dilated veins, no scratch marks. And the external genitalia was normal.
Okay.
On palpation, there was no tenderness or warmth. The liver was palpable 4 centimeter below the right costal margin in the midclavicular line. The liver was firm in consistency and rounded borders. Left lobe was not palpable. No splenomegaly, no other masses were palpable.
Okay. So it was a firm liver, isn't it?
Yes, sir. Yes, sir.
Right. Okay.
On percussion, the liver span was 8 centimeters and there was no shifting dullness. On auscultation, bowel sounds were heard, no bruit or venous hum heard.
Left lobe was not enlarged, only right lobe.
Yes, sir.
You couldn't palpate the left lobe. Okay. Only right. So it's very important to very carefully look at the left lobe of liver as well, whether it's uniform enlargement and down, and how much it is down from the epigastric.
Yes.
So left lobe also should be looked into when you're talking about the liver. So what does it? What type of liver you're looking at?
Sir, since it's a firm liver, that can be chronic liver diseases.
Okay. Right. Anyway, it's not cirrhotic. If you have a cirrhotic liver, what would be the finding here?
Sir, nodular liver.
Nodular liver, and what would be that?
Board.
The first will be nodular. What will be the
sharp borders?
So it will be a sharp border. Very good.
Yes.
Yes, continue.
Other systems
any abdominal wall, any veins or something? No veins.
No, sir. No dilated veins.
After looking at spleen, did you look for any splenomegaly by left lateral position?
Yes, sir. No splenomegaly was there.
So that's very important, especially in a chronic liver disease. If you're suspecting a chronic, you have to look at splenomegaly. Okay. Right.
Other system examinations were within normal limit. Respiratory, no tachypnea. Chest wall was normal. Air entry bilaterally equal and was clear. Cardiovascular system, apex beats in the fourth left intercostal space in midclavicular line. S1, S2 normal, no murmur. The child was an alert child and cranial nerve examination was normal. Motor system examination, bulk was symmetrical. Tone was normal, no hypotonia, and power was normal. Deep tendon and superficial reflexes were normal. Sensory, the child was able to appreciate touch and pain, sir. No focal neuroindigitives.
So, which system you would be respiratory system, because this child had a respiratory complaint. So there was no just
No.
the breath sounds were normal.
Yes, sir.
No crepitation. So
No, sir.
no crepitation. What about CVS? CVS is normal.
Yes, sir. CVS was normal. The child wasn't no failure signs.
Okay. You'd look for cardiomegaly.
Yes, sir.
You said about why we will be concentrating on we'll be looking at said that it's a doll-like facies.
Yes,
So
sir.
some of the GAs have
Cardiac
may
involvement.
have cardiomegaly as well, no?
Yes, sir. Pompey's
Cardiac
disease.
involvement. So it's very careful. Pompey's disease, or in some of the, not only Pompey's disease, some other GSTs can also have cardiac involvement. Okay.
Yeah.
Right. So what do you think after the history and examination? All pages, please write down your differential diagnosis after this.
Okay.
Okay,
So,
summarize.
yeah. My impression is that it's a 6-month-old male child, asymptomatically, previously asymptomatic, born to third-degree consanguineous marriage with a normal development, partially immunized, and nil relevant family history, with a history of cough and multiple bluish patches for the past 7 days. Examination revealed an active child with a normal growth and development. The child had doll-like faces and multiple ecchymotic patches with central nodularity was present. And the child had a firm hepatomegaly and a rounded border.
Okay. What other possibilities? Other PGs here in that? Can you just type your preference of first possibility, second possibility, third? All of you, please type your answers. Okay. Vishnupriya,
Yes.
just tell me the possibility.
Yes, sir. So I would like to consider chronic liver diseases like metabolic storage liver diseases like glycogen storage disease, and since it's a male, yes, sir.
Okay.
Since it's a male child, and I would like to consider malignancies as the second diagnosis. So since the child is having hepatomegaly.
You have written malignancy as the first possibility. I mean, why it is not a? You can do that. No, malignancy can be a first possibility.
Yes,
because child came with ecchymosis, and then there's a hepatomegaly, and you said that on examination child has pallor.
No pallor, sir.
No pallor.
No pallors.
From the look of the face, I think there was a pallor in the photograph. Anyway, the malignancy may come top in the list to rule out malignancy. So what type of malignancy you can rule out?
Sir, first will be leukemias and leukemias, lymphomas, or neuroblastoma due to hepatomegaly.
Neuroblastoma.
8.
So you said that there was no bone pain, no? So was there any?
No.
Did you look for bone tenderness?
Yes, sir. No sternal tenderness was present.
Sternal. What other area you look for bone tenderness?
Sir, sternal area and femur.
Not femur. Yeah, Abarna has another tibia, no? Up middle end of tibia. You can. So tibia is one area you have to look for younger babies. You can. So that's very important to look at it. And malignancy may masquerade as in many ways. What are the masquerading features of ALL or acute leukemias? They may present only as thrombocytopenia. They may present only as bone pain or joint pains, or they may masquerade as rheumatoid arthritis, or they may present as PUO. So these are so it may present in different formats, different ways. PUO, they may present as PUO, they may present as rheumatologic disorder, they may present as only as ITP or PUO. So I think malignancy comes in the list in the topmost. Because chronic liver disease is, even though you have only finding is because you are committing that doll-like faces and all these things, so you can put in the second list.
Okay.
But there is, what are the points against a chronic liver disease?
So there was no jaundice, and the child is no vomiting or failure to thrive.
Most important of chronic liver disease, or what do you say, metabolic? You said what do you call that? GSDs. Very important. Chronic illnesses. What do they have?
Sir, newborn hypoglycemias or jaundice.
But there is different. Any chronic liver disease or any chronic metabolic conditions. What will you have?
Hypoglycemia will be.
No, any other. You may have growth retardation. No, your height is normal. Your height is normal. Your weight is normal. So that points against the chronic illnesses. But still, you can consider. But you can consider slightly lower in the list. Okay. Okay. So, any other possibility?
Sir, hemophilia.
Hemophilia. Okay. So, why this liver acute liver? You think is it an acute liver, or why this?
Sir, since it's a firm liver, can be chronic liver.
Chronic liver, but you cannot have that both have both in hemophilia plus the chronic liver disease.
Yes.
But you don't want to consider the liver disease. So hemophilia may come in the list. Okay. Any other chronic any other process you have liver disease, chronic liver disease?
Metabolic liver diseases.
Metabolic liver disease. You think of, so your first possibility could be a malignancy.
Yes.
Second possibility could be a chronic liver disease or a hemophilia. Third could be an infection like you don't put in HIV here. You can put it, but sometimes we have seen viral hepatitis presenting with firm liver. So this child had a cough of 10 days duration and could be a viral. What are the types of acute? What are the infections in liver? Like what are the causes of acute hepatitis?
Sir, it can be due to hepatotrophic viruses
and non-hepatotrophic viruses. So you can have non-hepatotrophic viruses.
Okay.
Understand?
Okay.
It's in the season. No, you may have non-hepatotrophic. Even IMN can produce hepatitis and all this, but not in this age group. So think of viral infection. I think that can be slightly more than hemophilia. Starting, okay, because this child had an upper respiratory. We'll go to the investigation.
The patient's TBC was HP was 10.7.
Your comment.
Okay, sir, hemoglobin is somewhat in the lower side, 10.7.
Slow, somewhat not slow, lower. Okay.
And the WBC count was higher, sir, and it was lymphocytic predominant. And the platelet count is higher, that is 5,97,000. But the indices, though the patient is having a low HP, indices or within normal limits.
Okay, what type of anemia it is?
Sir, anemia of chronic diseases.
No. What type of, is it normocytic?
Yes, sir.
Normocytic. What are the 4 causes of normocytic normochromic anemias?
Sir, anemia of chronic disease.
Okay. What chronic disease? We have chronic liver disease or chronic?
Kidney disease.
Okay, kidney disease. Then? What other causes? Acute bleed. Very good. Acute bleed. Then? Acute hemolysis. And most important that never forget of a normocytic normochromic is a bone marrow infiltration. Bone marrow infiltrations by leukemias, lymphoma, they were present as. So any normocytic normochromic anemias, always look for any bone marrow infiltration. Okay?
Okay.
So this does not rule out a malignancy.
Okay, sir.
Then next.
Peripheral smear examination was normocytic normochromic blood picture, and there were reactive lymphocytes, thrombocytosis.
So when you say it's the reactive lymphocytosis, anyone in the chat box? When you say reactive lymphocytosis, what percentage of what type of, when you say atypical lymphocytosis, when you say atypical lymphocytes, more than, we have atypical lymphocytes more than TC lymphocyte. So reactive lymphocytes total more than 50,000, and atypical is more than 20%. Okay. Right.
The patient's coagulation profile, initially the prothrombin time, activated partial thromboplastin time, and the INR were prolonged.
Okay. Right. So this comes to a very interesting area. What are the conditions where you have both APTT and PT prolonged?
Sir, common pathway diseases like afibrinogenemia and also vitamin K deficiency, severe vitamin K deficiencies.
And very common to have what we usually see. You already made a comparison. No?
Liver diseases.
Yeah, liver disorders can produce. So this child had PT and APTT, both of no vitamin K deficiency. And liver disorders. Okay. Here's the possibility where both, if the child is sick.
DICs.
Very good. So sick child, DIC. Right. So think of DIC, liver disease, and okay, common disorder.
Okay.
And you may have both APT in a well child without any bleeding, well child coming to you with both PT and APT problems. Very common. Mild PT elevation, mild APT elevation. Very common.
Factor 7.
No. Anyone?
Antibiotic induced early vitamin K deficiency.
Antibiotic, okay, but anyone in the chat? Very common after viral infections. That usually lupus anticoagulant. No? Sometimes lupus anticoagulant. Maybe if you have a lupus anticoagulant present, usually after viral infections and all, you may. That's very common to see there. So you repeat it and then after a few days, or usually they are asymptomatic. And most of the references come to you from surgical field with the mild PT and APT problems. Okay, so this could be because you said this could be due to a liver disease, because you said a firm liver and then child had a hepatomegaly and firm liver and APT and APT is prolonged. So think of that. Okay. Yes, then next investigation. That was me already said. Any other investigations you have done?
Yes, sir. Blood routine examination, liver function test, total bilirubin was 1.5 and direct bilirubin was 0.9.
Okay.
The patient's OTPT were deranged.
OTPT deranged. Okay. Alpha is also high, no?
Yes, sir.
Protein. What about the albumin? What about the albumin?
3.1.
Any comment on that?
Low on the lower side.
Yeah, it's low.
Yes.
Okay. Yes. So after the investigations and any other investigation you have in?
Yes, sir. The fasting lipid profile was done for the patient, and it was abnormal, sir. The patient had hypertriglyceridemia, and they were
cholesterol
more
is
than, yes, sir. Okay. All of them were more than 95th centile for the age of the patients.
Okay.
To rule out infection-induced hepatomegaly.
With all these things, what are the possibilities? Tell me your, how do you rate it once more?
Sir, the patient is having hypertriglyceridemia and hepatomegaly. So,
so what do you think?
So it can be glycogen storage disease 1.
Okay, one of the possibilities could be a storage.
Yes, sir.
But what are the points against the GSD1?
There is no renal involvement.
GSD1, what is the most important thing that usually they'll have? What do they have? Usually.
Sir,
hypoglycemia, no? Hypoglycemia is very prominent. What are the GSDs which can have liver involvement? What are the
GST1,
yes,
GST3, GST4, and GST6.
6. Even 9 can also.
Okay.
So, which, according to you, which GSD can have this? You can fit in to this? Anyone in the chat box?
Can GST 4?
I think we'll GST 4, yeah, 4 can be there. Then 3B. I think we'll open this to discussion with our senior faculty here. Purushottam sir.
Well discussed, Priya, Ajit. At the outset, in the last part of the history, I think when you're going directly to the clinical entities, rather than that, at the end of the history, better plan is to categorize into different groups rather than going into individual entity. So the basic purpose of during the history is to answer 3 questions. First, is this bleeding significant? That is the one thing Ajit sir initially said, battered baby syndrome. Some other entities, it's not bleeding at all. It is not bleeding disorder, some other reason is there. So that is out in this case, answered there is a bleeding. Second thing is, what is the pattern of bleeding? Which will answer what is that basic defect. It's a primary or a secondary problem. Secondary is a coagulation factor problem. Primary is platelet number, function, endothelial, 1 milligrams, and that group. That you need to differentiate by the pattern of the bleeding. And the third is then acquired or inherited. These 3 questions you answer, and at the end you will get possibilities. 6 possibilities. It's an primer, it's an inherited or an acquired, and out of this thing it can be an isolated or a combination. So out of these different groups you can make. Here, very, very important point is, child was having a good weight, was asymptomatic up to 6 months, and in that there is a very, very useful point. You need to ask about the injuries in a newborn babies. You'll be having different points of injuries. One thing is umbilical cord fold. Second is the injections and immunizations, ear pricking, and the hair shaving and all. In this case, the child had an IM injection which didn't produce any problems. That is very, very important. That is a strong point. So in any situation where you're getting a no bleed in spite of such an injury is useful when an inherited problem presents late. So that is the importance of this thing. So that is a point which is arguing for an acquired problem. But you need not be 100% sure about this thing, but that is one strong point. Injection once only. Suppose 3 primary injections taken, IM, no bleeding, that is strongly suggesting an acquired problem. So that point is very important. So rather than going into individual entities, group of the disorder you mentioned at the end. So it seems to be the pattern of bleeding seems to be larger ecchymosis, no petechia, and nodule. So that again is it's a coagulation factor problem. So a little bit point for an coagulation problem, possibility of an acquired is high. In a 6-month-old baby, when you go to an acquired problem, a little less chance is there. So always there's an inherited problem also. And then at the end of this thing, your liver palpation, that's a very, very important point. You should have mentioned about the measurement in the epigastrium and the mid-clavicular end, because all the entities you're talking about producing diffuse enlargement with a firm. If it's a localized enlargement, right lobe only, that argues that it can be malignancy only, like your hepatoblastoma or something. All the other things should be producing diffuse enlargement, storage disorder, or your other liver cirrhotic problems, all the other things. So left lobe not involved. That's a bit unusual. Then you have a little bias by the appearance of the facies is a doll-like facies. In that situation, you expect the liver in a glycogen storage disorder type 1, it's usually not that firm liver, it's a soft liver. And in that situation also, you need to have mentioned about the tone and the tongue. And heart, as Dr. Ajit said, because those are belonging to one of the storage disorders where there is no bleeding manifestation. Bleeding manifestation in the storage is only in von Gerg. So von Gerg, and if you're going for a storage disorder, what is the problem here? In a storage disorder, it's just getting stored. There is no functional derangement in a storage disorder. It is not producing cytopathy. The enzyme changes, bilirubin changes will not occur in type 1, 2. Usually, it may be type 3B and 4, as Ajit sir said. In the combination, when you're suspecting more of an von Gerg, you'll get more of the other hypoglycemic episodes and hepatomegaly, all like fasces and all, not directly going in for a hepatic failure situation. It's unusual. So those are points against your argument for a storage disorder. There is a cellular injury here. So one point here, as we suspected a coagulation factor problem, the liver production of the bleeding can be von Gerg with the thrombocytopenia, will produce a primary hemostatic problem. If it is a liver disorder with a coagulation problem, you will get a coagulation type of breathing. And a nodular argues for a coagulation problem. And your lab report also is supporting the transaminase is the synthetic defect is there. So that is it's a more likely to be a liver injury type of problem, a little less likely to be a storage problem. So other thing, the hemoglobin part, rather than going for a 2-element, because 6-month-old baby, even though WHO says the anemia, even when you're calling as a 6-month-old baby, 10.7 is not that anemic. It's almost normal. If you go by the criteria, WHO and all, you may put it as an anemic group. Actually, 10.7 is not that anemic. So should we consider biseto and all? No. Platelet is normal. Hemoglobin is almost normal. Not much of a impairment. Definitely, it's a liver problem, but I'm not for a storage problem. It's because storage problem, by the time injury occurs, it will not be 6 months, it will be late. So there must be some other injuring problem. There again, I can't explain the focal pathology, as you said, diffuse enlargement you expect in any of these things. I get that much only.
Okay, thank you, sir. And can I, Mohandas, 2 minutes? Can I take 2 minutes, Mohandas?
Sure.
Vishnupriya, can you show the slides which I had sent? So this is what I would like to. Can you just okay? Next slide. So as we already said, any bleeding you have to find first step. Look for whether child has any critical bleeds. Like most important, what are the critical areas? One is the head. So any child, especially a neonatal cholestasis. What is the first drug that you give? If they come to the casualty, you give vitamin K to prevent a IC bleed. So whether child is in shock, whether child is having critical bleeds, you have to stabilize and give emergency medication. That's very, very important. Any bleed, you first see whether the child has any critical. Any child with hemophilia comes with headache. You don't send the child to any CT scan or MRI. You give a first dose of factor, whether it's factor 8 or factor 9, give 1 dose of factor. Then stabilize, because we have seen children who died on the way to the MRI and all these things. If the child came, any hemophilia coming with headache and all. Next question. So that will be the first thing that you. Next question that you to ask is whether is the bleeding proportionate to the trauma. Are you really dealing with a bleeding disorder? Because if it is proportionate to the trauma, most probably you're not dealing with a bleeding disorder. Or whether it's an isolated bleed, because you may have isolated bleeding, which may not be related to a bleeding disorder, like an after a head injury, you may have IVH or of some, or as Sarah said, site and type of bleed, and unusual bleeds. Unusual sites are very important. Next slide. So look for all these things, sir. So iliopsoas bleed, you can produce. We have seen in hemophiliacs, they come with abdominal pain. and they may be in shock because of ileoceras bleed. Next slide. So detailed history to elucidate whether which group they belong to, whether it's belong to the vascular on platelet, that's called the phase 1, and whether they belong to the coagulation disorder. Next. So for this, some of the histories are very important: age of onset of bleeding, type of bleeding, and all these things. And easy visibility without coagulation, you may have medication. We'll go to the next slide. Can you go to the next slide? Yeah. So this is very important, which I already discussed. Skin and mucous membrane is platelet disorder. The coagulation deep bleeds into soft tissue or joints. Petechiae, you have more in of platelet disorder. Ecchymosis, which will be large deep in coagulation disorder. Hemarthrosis, and immediately after bleeding immediately. This is one point which you should. Bleeding immediately after surgery, that could be platelet. And delayed bleeding is occur in coagulation disorder. Next. So very important to look at all these things. Recent vaccination. So if a patient does not have any bleeding till 1 year, like most of the bleed, they'll have minor traumas, they'll have vaccinations, they'll have many other religious surgeries like circumcision and all these things. And so like 1 or 2 years, if they don't bleed, most probably if there is no ecchymosis, you're ruling out congenital problems of severe type. Maybe minor, they may present later. We have seen minor hemophilia in the mild variety presenting later after surgery. And so, but red flag signs, you have to say, if they have weight loss, night sweats, bone pain, fatigue in a child with bleeding, fatigue, especially platelet type of bleed, you have to have that in mind, that am I dealing with a malignancy or not. So this is very important. Okay, next slide. So which we already discussed about that. Next slide. Next. So you have to have a focused examination on these things: pallor, ecchymosis. Look for any what do you call that? If you have bleeding with hemangiomas in the liver, we had one child who was treated initially as ITP, chronic ITP, but when somebody took an ultrasound, had a huge hemangioma in the liver. What do you call that condition?
Kesabat.
Always look for splenomegaly, look for rash. Next. Focused examinations, look for hepatosplenomegaly and lymphadenopathy. So stabilize, which I already said. Assess. Next, go to the next slide. So this is very important, screening. So these are the screening tests. If you have only platelet type of bleed, you do a smear and platelet from CBC, and you can get a diagnosis. If you have coagulation type of bleed, you have to look for APTT and PT. So this I got, I think I taken from the OP guy actually. You go and look for that, and this is very, very important for screening test of next slide. So I think next slide. I think we have gone for sick child. So if it's a platelet type of bleed, sick child, you have DIC, infection, HUS. Next slide. And I think we'll skip that. Very important, especially in a sick child. One important thing that you have to look for whether the child is. We have seen children with meningococcal presenting with what type of bleed they have. What is the scar called? What type of skin manifestation they may have? Cigarette burn appearance. Okay. Next. So HUS and HUS we have to always look for, especially in a child who has vasculitic type of rash. Next slide. So ITP is most common, and neonatal aneurysmal thrombocytopenia is one condition which may be very serious, especially in a child in a newborn babies. Next. So you have to classify whether it's a sick child or a well child. So these are the causes for a well child, SLE, ABS. Next. Then decreased production could be congenital rhabdoid. Next. The acquired causes are bone marrow infiltration, bone marrow injury, lack of nutrition like B12. B12 it can produce thrombocytopenia. Next. Next slide. So infiltrations, leukemias, lymphomas. Next slide. Okay, go fast. So this is just show to go to this that slide, CBC slide. So what's the diagnosis here? What is this graph shows? From the graph itself, you can see that this is the lymphocyte. See that it is more shifted to left. So from here itself, we can say that most probably you are dealing with a malignancy. No? Platelet is also low in the left side. Platelet is also low. So platelet leukocytosis and hemoglobin is done. Look at the neutropenia. WB. Okay, next. Yes. Okay. Next. Congenital. I think we'll stop here. So already, can you go first one or two slides? This we already discussed. What is that? What is this? This is the dyskeratosis congenita, leukoplakia and reticular patternal skin. And next. Okay. And most common is von Willebrand's disease, which can produce von Willebrand disease can produce thrombocytopenia.
Type 2B.
Which one? Very good. Type 2B. Okay. So I think we'll close this. Parvati madam, Sushma madam. I think we'll close that.
Well discussed case. Thank you, Ajit. Welcome to Thrissur, Ajit Kumar.
Thank you, madam. Thank you. Sushma madam. Sushma madam. You want to help? Sir? Mohandas, I want to ask about the GST part. Mohandas,
okay.
Can you unmute?
I am unmuted, but I have a very bad throat now.
Okay. Because you are an expert in that GST.
Usually you will have short stature, no?
Yeah, that's what I'm saying. If you're likely to be.
Actually, he is 69 centimeters for a 6 feet.
It's taller than normal. So, Mohandas,
First of all, we should verify whether the measurement is correct.
Yeah.
And we should see whether the mid-parental height is more.
Yeah.
Then the GST, the thing is, the initial months, probably the growth need not be affected that much because the liver is not becoming abnormal initially. Okay. Gradually, the storage occurs and the liver, the short stature, everything develops. So initially, there need not be that much short stature.
The initial stages. Okay.
Okay. So it does not fit into type 1, but it could be.
Okay. Because in type 1, you can have bruises because of thrombocytopenia.
Actually, it's not thrombocytopenia.
Coagulopathy cannot be explained by that type.
Right. Actually, Mohandas, I think it's due to platelet aggregation and adhesion, not thrombocytopenia. Most of this, what this is, mainly due to platelet aggregation and adhesion.
Yes, in type 1, it is mainly platelet type of bleeding, but here it is coagulopathy.
And that platelet type of bleed is basically due to the platelet function.
Okay.
Yeah. Okay. Anyway, how will you confirm your diagnosis of GSD? Nowadays, it's very easy, no?
You're muted, Vishnu. Please mute us.
Muted, Vishnu.
Supriya, you are muted.
Sir, so we can do liver biopsy, or we can go for genetics tandem mass spectrometry.
Tandem mass spectrometry will not give any positive result here.
Tandem mass you cannot have. Clinical exome, I think, and more better than liver biopsy. I think, if you have good clinical picture. Parvati madam, you want to say something?
No, nothing.
Okay. Sajida? Okay, Geeta? No. Geeta?
Murali was asking something. TD Muralidharan.
No, what was the final diagnosis in this child?
There is.
Have you made a diagnosis?
Identified.
We have made some differential diagnosis only. A chronic liver disease. Chronic liver disease. It could be a GSD, but there are many points against.
Any genetic test already done?
No. We have. They are actually traveling people. They travel 10 months a year. And they don't have any schemes, so I'll send it to Mohandas if they come back.
Ajit, ഒരു കാര്യം ചോദിച്ചോട്ടെ, എനിക്ക് തോന്നുന്നു ഇതിന്റെ PG ഡിസ്കഷൻ ആകുമ്പോൾ he has discussed it well, but ഈ എത്നിസിറ്റി അതിനൊക്കെ ഭയങ്കര ഇമ്പോർട്ടൻസ് കൊടുക്കണം. ബിക്കോസ് ഈ ടോൾ, അതുപോലെ നോർത്ത് ഇന്ത്യൻസ് ആകുമ്പോൾ ടോൾ ആയിരിക്കും. അപ്പം അതുകൊണ്ടാണോ ഇനിയും നമ്മൾ ഷോർട്ട് സ്റ്റേച്ചർ ഐഡന്റിഫൈ ചെയ്യാത്തത്? പിന്നെ അതുപോലെ as you discussed, it should be in the lines of severity. സ്കിൻ ബ്ലീഡ് ആണെങ്കിൽ മ്യൂക്കോസൽ ബ്ലീഡ് ഉണ്ടോ? പിന്നെ ഫണ്ടസ് നോക്കിയത് ഐ ഡിഡ്ന്റ് ഹിയർ, ഐ ഡോ നോട്ട് നോ. ഫണ്ടൽ ബ്ലീഡ് ഉണ്ടോ? അങ്ങനത്തെ ഡിസ്കഷൻസ് കുറച്ചും കൂടെ വരണമായിരിക്കും.
Definitely. He has told about fundal bleed and all this.
I missed it. That's why. അതുപോലെ because more common ones should be discussed more, because ഇതിലെ ഒരു ഡോൾ ഫേസ് എന്ന് പറഞ്ഞാൽ നമ്മൾ ആദ്യമേ പോയി എക്സാമിന്റെ അടുത്ത് പ്രസന്റ് ചെയ്താൽ ടിപ്പാണ്.
That's what I was saying. So you should not come. You can always describe the finding, then come, because when you say mid-diastolic the pre-systolic accentuation and all these things, and you're committing to a diagnosis of MS. The same way, don't commit to something in the beforehand. So Lediga, anything? Lediga was a sector.
Vitamin K കൊടുത്തപ്പോൾ കറക്റ്റ് ചെയ്തല്ലേ മറ്റേ PT APDT ഒക്കെ? It was short.
Lediga was corrected. Lediga
in this, yes, corrected. It was corrected. Actually, the father was not available, hence MPs could not be taken.
Vitamin K
was of average height.
ഇവർക്ക് വൈറ്റമിൻ കെ ആന്റിനേറ്റലി അല്ല ഡെലിവറി കിട്ടിയിട്ടുണ്ടോ? അതൊക്കെ ഹിസ്റ്ററിയിൽ പറയണം.
Actually, the mother doesn't know many of the details, and there are no records also available.
Anyway, nice case, interesting case to be discussed. I think we can you close? Lediga, any other anything to say? Lediga? Lediga, anything to add? Lediga,
you can close the session.
Yeah.
Wish you all happy New Year. Happy New Year to all of you.
Thank you, madam.
Thank you, madam. And wishing
you all. Lediga, anything to you just close? You can close the session, Lediga.
On the take voice rest.
Thank you, Mohandas sir and Ajit sir, for giving me this opportunity. But actually, there are few points to be. We also were not clear about many points. Because of the nodularity only, we considered this child has having a coagulation problem, and after detecting the firm hepatomegaly, we thought it should be a chronic liver disease. But in the absence of a failure to thrive and a poor development or any other jaundice or any other stigmata of liver disease, we thought initially it could be a storage disorder. But the point we couldn't clear was that why is there a coagulation problem in a child without much of transaminase elevation or anything? Because as Purushothaman sir already said, the liver dysfunction comes late in a storage disorder. But then how can we explain this coagulation problem with this storage disorder? But if it is a hepatitis or a something that is causing the hepatocyte injury, then why isn't there much of jaundice? So there are a few points I couldn't clear.
Okay. Anyway, so we'll get back to this allied group with the answers when the child comes back. with some of the tests. I hope that
I was expected to come today for admission for liver biopsy. I think they have just run away.
Okay, thank you. Ladika,
okay, thanks.
Can we close?
Vote of thanks.
Please.
Thank you everybody for joining and making this a discussion very fruitful for all PGs and even the faculty. And thank you especially so many faculty from Jubilee, Amala and Thrissur IAP who have joined, and all the senior faculty who have contributed a lot to this discussion. Thank you everybody and Happy New Year.
Happy New Year everyone.